Stephen Aradi completed his medical school at the University of South Florida Morsani College of Medicine. He then completed an internship in internal medicine and residency training in neurology at the University of Pennsylvania. Following fellowship training in movement disorder at USF, he joined the faculty in the Department of Neurology, where he serves as co-director of the HDSA Huntington Disease Center of Excellence at USF. His research interests include clinical trials for new therapies in HD, motor symptoms in HD, and the use of digital measures and technology in neurology.
Good morning. Thank you so much, Katie, for that kind introduction. And thanks everybody for your attention and for the opportunity for me to come here and speak with all of you and share time today. So as Katie said, I'm going to give an overview of what are the different kinds of movement and motor symptoms that can come up throughout the course of HD, as well as highlight some of the different psychiatric and behavioral symptoms that can come up. We'll also talk about the variety of different strategies that are available to treat these symptoms throughout the course of the illness. Necessarily, this is a limited time, so I'm not going to be able to cover everything that can come up, but that's what the hype panel is for. So definitely write down any questions that you have, something that I didn't address that you'd like to hear more about. Okay, here's the brief outline of what we're going to talk about for the next hour. First, I'm going to spend a very brief amount of time on what is HD, because all of you know very well what HD is and probably better than I do. I'm going to spend a little bit of time talking about the idea of the pre-manifest phase and keeping in mind that we can treat some of the subtler symptoms that can occur before a formal diagnosis is made. We're going to talk about the different motor and movement symptoms in management, the psychiatric and behavioral symptoms in management, and then at the end, a brief time putting it all together. So what is HD? This is a genetic, meaning inherited neurological illness. This is an illness that runs in families. It's caused by an expansion of a part of the Huntington gene. So somebody who carries this expanded gene is called a gene expansion carrier. The way that this illness is passed through families is it's autosomal dominant, meaning that every child of a person who is affected has a 50% chance of having inherited that expanded gene. And that 50% applies to each child independently. HD causes symptoms in 3 main domains that progress over time. And very importantly, there are many tools that are available throughout the entire spectrum of HD to treat these symptoms and improve quality of life. And finally, every person's journey with HD is different. So the 3 main domains of symptoms that arise in HD are motor or movement, psychiatric and behavioral, and cognitive symptoms. So I'll speak first about the motor and psychiatric, and then there will be another presentation a little bit later with Dr. Anderson on cognitive symptoms. So the idea of the pre-manifest phase comes down to the fact that right now, the formal diagnosis of Huntington's disease is made when somebody has what we call unequivocal motor syndrome. So on the neurological examination, there are clear and unequivocal signs that are consistent with what the movement symptoms of HD look like. What that means, though, is that there is a period of time before those movement symptoms are present and meet that threshold when somebody may not have a formal diagnosis of HD, but we do know from lots of large studies that people can develop a number of different subtle movement, thinking, and psychiatric symptoms before that diagnosis is made. So a lot of these slides are going to focus on the kinds of symptoms that come up during the full manifest phase of the illness. So once the formal diagnosis is made, but a lot of these tools and approaches apply to individuals who have not received the formal diagnosis yet, and we can still treat those symptoms in their subtler forms. This is a figure that just illustrates that idea that if you look on the far left, that's pre-symptomatic. So somebody is a gene expansion carrier, they carry that expanded gene, but they don't have any symptoms yet. At some point, they will start to develop subtle problems with maybe depression or anxiety or subtle changes in coordination during what we call the prodromal or pre-manifest phase, but they don't yet have the unequivocal motor syndrome. Once on a neurological exam, that motor syndrome is identified and present and meets that threshold, the diagnosis is made. But as you can see with those other signs for motor, cognitive impairment, and chorea, some of those symptoms can begin before that. And it's important to recognize those symptoms and treat them just as you would with somebody who has already received the formal diagnosis. So what are the different kinds of motor and movement symptoms that can occur in HD? I think of them in two big baskets. So the first big basket are problems with unwanted involuntary movements. So these fall into a lot of different categories that have obscure names and jargon. And so we'll talk about what those words mean just because you'll hear them. And I think it's nice to know what we mean when we talk about these different kinds of movement disorders. The first and the most characteristic is chorea. There are several other movement disorders that can also occur throughout the course of HD, and we'll talk about some of these. These include dystonia, bradykinesia and rigidity, tics, and myoclonus. The other big basket of motor and movement symptoms that we pay a lot of attention to are problems with voluntary motion or involuntary movements. So these include balance and coordination, as well as speech and swallowing. So how do we measure these motor symptoms? How do we identify them and think about them and make treatment decisions about them? So all of it, first starts with a neurological examination by a neurologist. We go through a whole structured head to toe, lots of different maneuvers and reflex hammers and everything like that. And that gives us a lot of information just in general about the neurological exam. And specifically with HD, there's a standard examination protocol with a rating scale called the Unified Huntington's Disease Rating Scale. This was developed by the Huntington Study Group in the 1990s, and at this point is largely the gold standard for measuring especially the motor symptoms of HD. This is a picture that is very small on this slide, but it's what it looks like, what the motor assessment looks like. Each of those all caps sections are different movement symptoms, and underneath each of those are descriptions of a rating from 0 to 4. When you see your HD neurologist, they'll go through this standard assessment and check all these things each time, assigning a score that allows us to track changes over time and also to see if the score improves with starting medications or other interventions. So first we will talk about chorea. So chorea is the sort of hallmark and most known picture of movement in HD. What this is involuntary movements that have the following attributes. These involuntary movements are irregular, they're random, they're non-patterned, they are jerky, twisting, or flowing, and they're often worsened with stress, excitement, fatigue, or focus. So chorea can occur anywhere in the body, all the way from the upper face, the lower face, and the tongue, the trunk, the arms, the legs, and even the diaphragm, affecting breathing and speech. So chorea has a huge spectrum, both in terms of where it can present in the body and in terms of how severe or not severe it is. Ultimately, throughout the course of HD, chorea does have lots of different consequences and affects function and quality of life. Chorea can cause problems with dropping objects, handling and using objects like utensils, tools, a phone, or grooming. It can make it harder to get dressed. It can make it harder for a person to walk, and it can impair their balance and lead to an increased risk of falls. And it can affect, again, the speech and voice. And so all of these things converge onto effects on functional impairment and day-to-day functioning. So what do patients say? What do people who have chorea say about their chorea? And what do companions of people who have chorea say about it? So there are a couple of really good studies that have been done in the last couple of years looking at this and really taking information from the people who are directly affected by it. So in one study, they collected a number of responses, free-form responses to lots of survey questions from both people who had HD and companions of people who had HD. And a lot of their responses to these questions fell into three big themes. So one theme was vigilance for chorea. Both people who have chorea and the companions of those who have chorea mentioned watching out for it, especially early on, thinking about little movements. And then throughout the course of the illness, it can occupy a lot of attention. And so that vigilance is something that was one of the big themes of these responses. Another theme was the stigma of chorea. So being out in public, as Katie said, sometimes others might suspect that somebody who has chorea is intoxicated or something like that. And that is something that is on people's minds. The third theme that kind of came out in these responses was that chorea does have effects on independence and social life. All of these considerations can make it harder for somebody to feel comfortable to go out and see friends. And these are different themes that we want to keep in mind as we talk to our patients and caregivers about chorea. In another study by the same team, they asked some questions. Number one, how important is it to you to manage your chorea. On the far left there of that top graph is very important. So most of the responses from both people who had chorea and their companions responded that it's very important to treat their chorea. On the bottom, they asked the question, they asked them to agree with the statement, my current medication helps manage my movements. And most of the responses cluster in the middle, neither agree nor disagree. So these kind of illustrate that managing chorea is important, and we still have some work to do in terms of managing it better, but there are lots of really good options for it. So we also talked about other movement disorders, so other problems with unwanted involuntary movement. So some of what these definitions are, so for dystonia, dystonia is characterized by involuntary pulling or twisting, repetitive or posturing movements. Sometimes these can be painful, and just like chorea, dystonia can affect any part of the body. Bradykinesia and rigidity occur together, and when they occur together, they are called Parkinsonism. So not Parkinson's disease, but the combination of those two features. So bradykinesia means slow and delayed and small movements, and rigidity means stiffness in different body parts. So slowness and stiffness tend to occur together. A tic is an unwanted repetitive sound or movement that's often preceded by an urge. So these are movements that a person is aware of. They're often aware of making the sound or movement, but it's not something they really want to do. Tics are important to recognize because they can occur in HD just as a feature of HD, but also sometimes as a side effect of certain medications that we use. And so that sort of highlights a theme that we're going to talk about in terms of considering how we use medications to treat all these symptoms. And finally, myoclonus is not as common in HD overall, but it can occur. A myoclonus is a rapid lightning-like simple jerking movement. So these can occur in anybody. All of us have probably experienced this at some point. A hiccup is myoclonus of the diaphragm. And when you're falling asleep on the couch and you have a quick jerk of an arm or a leg, or you have a dream that you're falling off a bicycle or something and you jerk, those are called sleep myoclonus, and those are normal examples of myoclonus, but sometimes it can happen in HD and be disruptive. So we've just talked about a bunch of different kinds of involuntary movements. How do they occur throughout the course of HD? So this slide, we're going to talk about a little bit about that, but remember, everybody's journey with HD is a little bit different. But in general, so very early on, and again, even in those who have not yet received the formal diagnosis of HD, you can have very slight changes in balance. There can be very slight early chorea. Usually this starts out with looking like little intermittent fidgety movements. And there can be slightly slower eye movements and body movements. In the middle stages of HD, the chorea generally gets worse. Chorea generally becomes the most prominent movement symptom, but not for everybody. In addition to the chorea worsening, some slowness and stiffness often develops as well and becomes more notable. And finally, balance, coordination, speech, and swallowing can become more affected. And finally, during the later stages of HD, for most individuals, chorea tends to reduce, it tends to slow down. And the slowness, the stiffness, dystonia, those tend to become more prominent. And finally, walking, swallowing, and speaking become much more difficult. But again, everybody's journey is a little bit different. Not everybody follows the same roadmap. So how do we approach these motor symptoms in HD? How do we make decisions about what to do? So the priority of management is to treat the person, not to treat a symptom. So if a symptom is mild, if it's not causing functional impairment or harm or distress to a person, then we don't have to start any treatments. At the same time, the right treatments can improve function and quality of life. So identifying what's going on and making strong decisions together is important. There are lots of medication options and lots of non-medication options. Using both together can often be a great combination. And a very important point is that all medicines have side effects, and many medications may treat multiple symptoms. So this is a theme we'll come back to at the end. So there are lots of intelligent ways to make decisions with medications, and it's very important to pay attention to both good and bad things that the different medicines could be doing. And finally, we're a team, and teams work together and teams make decisions together. So everybody that you see when you go to an HD clinic, they're all part of your team. And the entire goal is to make decisions to help your lives get better. So what do we do about chorea? We talked about how chorea can get worse in situations where one is stressed out or anxious or tired. So one of the first things that can be done is to try to, as best as possible, maintain a calm environment, reduce stressors where able, and to treat coexistent depression or anxiety, because all of those things can affect the movement disorder and vice versa. When chorea does become disruptive, there are lots of medicines that are available to treat it. There are two that are approved by the FDA. These are tetrabenazine or xenazine and deutetrabenazine or Austedo. There are other medicines that we use, some very commonly, some less commonly, that are off-label, meaning that they don't have an approval by the FDA, but based on many years of use and experience, we know that some of these are very effective. So the most effective class of medicines is called neuroleptic medicines. The one that we use the most is risperidone. Others include olanzapine, and then sometimes we use some older ones like haloperidol. And finally, amantadine is another medicine that probably has a very weak anti-chorea effect. It's not very strong, but as we'll talk about, amantadine sometimes has some other benefits. And so we do sometimes pull this out to treat mild chorea. In addition, there is another medicine called valbenazine, which is in the same class as tetrabenazine and deutetrabenazine, that is being evaluated by the FDA for possible approval this year. There were promising results from a recent trial of this medication at treating chorea. So what do we do about all those other movement disorders in HD, all these other involuntary movements? Dystonia, again, is involuntary pulling, twisting, posturing, sometimes jerky and sometimes repetitive, and sometimes painful. So oftentimes dystonia can occur more predominantly in a certain body part or a certain body region. For instance, the neck is a very common place for this to occur, or the leg, and especially the foot and the calf. When dystonia occurs in a very focal body part like that, botulinum toxin injections are a really good option because they're a purely local therapy. And we'll talk a little bit more about what botulinum toxin injections are. There are also other medicines that can be used. Examples are trihexyphenidyl, baclofen, and clonazepam. Bradykinesia and rigidity, or the combination being called Parkinsonism, so slowness and stiffness. This combination of movement symptoms, again, so it occurs in HD on its own, but it is a very common side effect of many of the medicines that we use to treat chorea. So when we identify slowness and stiffness that's bothersome, one of the first steps is to step back and look at the medications and see if some of the medicines we're using for other symptoms are actually worsening the slowness and stiffness. And maybe we need to balance the doses out a little bit better. And when somebody develops tics, so again, these repetitive, unwanted sounds or movements, the anti-chorea medicines we talked about, especially tetrabenazine, deutetrabenazine, and risperidone and olanzapine, those can all be useful to treat these tics. There are other options as well for tics, including guanfacine, clonidine, and topiramate. But again, and we'll talk about this more at the end too, tics are another symptom that sometimes can be caused by the anti-chorea medicines, especially something like risperidone. And so again, keeping in mind that we sometimes have to think about the medicines and reevaluate them periodically is important. Finally, myoclonus, so the rapid jerking, lightning-like movements. Clonazepam and other benzodiazepines like, say, Valium can be useful, as well as valproic acid or levetiracetam. I know that a lot of these medications may not be familiar, and they're all weird words always, but more so just to illustrate that there's lots of options, and so that options are out there. So what are botulinum toxin injections? So there are lots of different brand names for this. The one that most people are familiar with is Botox, but there are others. Botulinum toxin is a medication that's injected into specific muscles that are causing involuntary contractions and postures or stiffness. What this medication does is it induces a therapeutic weakness of the targeted muscle. So by identifying the muscles that are responsible for the posture or the pulling or the pain or stiffness, we can pick the specific muscles that are causing this the most and inject this medicine into that muscle and make it weak enough to hopefully reduce the movement, but not so weak that it impairs whatever other function that muscle is usually trying to serve. Because this medicine's injected into the specific target muscles, it doesn't have some of the more widespread side effects that other medicines that you take by mouth might, like fatigue or mood changes or confusion or dizziness. The effect of this medicine, once it's injected, can last up to 3 months. And so botulinum toxin injections are approved to be given every 3 months. So if you and your doctor identify that this might be something to try for some dystonia, for instance, it would be something that you would have every 3 months going into the office. It's done right in the regular exam room. It usually takes about 10 or 15 minutes, and it's done every 3 months. The doses need to be adjusted over time. There's a little bit of trial and error sometimes when there's more complex movements to pick the right muscles and also to pick the right doses. And because movements change over time, we have to change the muscles and doses sometimes. So, when you're first starting out, it may not have a very robust effect, but you'll work your way up to find the right Goldilocks zone of the right muscles and the right doses. Because this medicine is a solution that's injected in the muscle, and because it causes weakness, sometimes the medicine can spread to other muscles that you're not really targeting. And so depending on where you're getting the injections, there are some local side effects that can occur. And your doctor would talk to you about that and warn you about that. Okay, so to tie a lot of this together and then segue into the next phase of talking about psychiatric symptoms, a really important theme is that care for HD is multidisciplinary. You are the center of the team here. And all of these other circles are everyone else that's on your HD team: the neurologist, psychiatrist, neuropsychologist, physical and occupational therapists, speech and swallowing therapist, social worker, dietitian, genetic counseling, nurse. There may even be others that there are not enough circles for on the figure. But you are the center of this team, and decisions about treatment are made together. So what are some of these other disciplines that we use to treat the movement symptoms in HD? One of the biggest disciplines is physical and occupational therapy. So physical and occupational therapy can be really helpful for a couple of things. The thing that we most often use it for is to help with gait and balance. So when somebody has balance and walking difficulty, PT and OT can really help to maintain their safe mobility, maintain their independence getting around, and reduce the risk of falls and injuries. Occupational therapists in particular can also address problems with dexterity and using one's hands to perform certain important tasks. Another useful angle for PT and OT is that they can often be ordered in the home as part of home care and home health care. This can be a really good option if leaving the house is difficult. And it can also be helpful to have them come into the home to optimize the environment, to maximize mobility and safety at home. In addition to physical and occupational therapists, just general physical exercise has great benefits for mental and general health. And those benefits can sometimes translate into HD symptoms. So exercise can take all sorts of different forms depending on a person's situation. So maybe you're a really high intensity distance runner or biker, or maybe yoga or Pilates is more your thing, or maybe it's harder for you to do some of those things, but there are lots of really good seated exercise protocols and chair yoga and lots of other things that can be done to incorporate physical exercise into somebody's life that can help with these symptoms. The other discipline that is really helpful for some of the motor symptoms we've talked about are speech and language pathologists. So a speech language pathologist can use a variety of different bedside and imaging assessments to evaluate the safety of swallowing. They use this information to recommend rehabilitative exercises and strategies to improve the safety of swallowing, as well as recommend changes in food and liquid consistency over time. Eating and drinking is one of the most central aspects of living, and pleasure from eating and drinking is really central to our life experience. So a speech and language pathologist can be so helpful in trying to keep that aspect, that central aspect of the human experience, safe and pleasurable for as long as possible. This figure is an example of how the consistency of food and liquid can change through the course of the illness. And so they meet in the middle of this pyramid. So at the larger ends of each pyramid, there's regular food, there's thin liquids, and as swallowing becomes more difficult, the consistency of food can change, or the recommendation for the consistency of food changes, and the same for liquids.